So at this moment, I'd like to introduce Dr. Robert Fitton, who is the Director of Palliative Care at St. Vincent's Medical Center. And Dr. Fitton is going to dispel the myth between hospice and palliative care and explain why it is important and give us some tips on how to advocate for our patients who need palliative care, not necessarily hospice care. So it is my great pleasure to introduce Dr. Robert Fitton.
Good. All right, guys, so just some business. I'll stay close. So just some business. So anyone that needs continuing medical education, physician assistants, nurse practitioners, physicians, there's a separate sign-in sheet. It's kind of a loose leaf piece of paper. We need that. So if you've claimed credit before, you know the drill. We need to have that document, and the evaluations are not optional. We need the evaluations back. So we will get them to you. Just put on that sheet your preferred method of contact, whether it be by email or snail mail. Okay, so if you just do that to break and you just get that information back to us, we'll get those out sometime next week for those of those. So let me just see where I am. So disclosures, just to go, so I have no financial disclosures and no conflict of interest to kind of disclose. When I give you facts, they're facts. When I give you opinion, they're my opinions. They're not necessarily those of my employer. That's kind of the tweet proviso. So I work for St. Vincent's Health Center, but we're part of a huge health system, Ascension Healthcare. It's the biggest faith-based organization in the country for healthcare providing. So just need to kind of put that out there. So kind of my objectives, Corey kind of hit on it, some of what I've heard actually, in just some of the passing remarks and some of the introductory remarks. Really, we're going to talk about really what do I mean when I say palliative care. Talk about the workforce needs. Talk about us. A lot of us are in the we're in the education business, but we're part of it is to prepare the next generation of providers, and the needs are evolving. So the questions, it's to everybody. Its objective is to take away from this is, are we really preparing people for really where healthcare is going to be in 2000, if it's everyone's 4 years, 2020, 2021 and beyond, and that's going to continue to evolve. We're going to talk about some of the successes of inpatient palliative care and kind of springboard into community-based palliative care programs. We're going to talk about what we call market disruption, right? We talk about the Ubers of the world and the Lyfts of the world, what it did to the taxi business and the Netflix and what that did to going to movies and those kinds of, when we talk about that, it also applies in healthcare. And we're going to talk about a little bit about the business. People say, well, I'm in healthcare, I don't need to know about the business. You need to know about the business, guys. Either you are at the table or you are on the menu. It is a business, so you need to understand it. You don't need to know all the nuances of it, but you just need to have that good basic education about the how things are paid for, where the money comes from, and it's a little bit boring, but you have to understand this stuff because it's vitally important. Because we're in a school of business, and they're always trying to figure out, the next step. You've got to acknowledge that. People say, I'm a physician, I don't need to know. You do need to know it. You do need to know it. So that's what we're going to do. So I hate the word palliative care, by the way. Let me just put that as a full disclosure, because it just conjures up so many things. So just when I say palliative care, everyone says hospice. Usually that's what I hear the most. Or people say I've never heard of it, which is actually much better for me. It kind of helps me when I go in to see patients when they've never really understood that word. But the most commonly association is really that with hospice. So I try to come up with clever different names. So I say I'm a supportive care team. So you look at our brochures in our cancer center, we can't say the word palliative care. So we say supportive care clinic, right? Because we can't use that word palliative care because it sounds like hospice, right? So I keep saying the more we keep changing our name, people are going to continue to figure out really what it is that we do. It might be a futile exercise, but we do it anyway. But we're really focused on symptom management. Really, that's really what the core of it. And all the symptoms that a holistic person might have, right? Their physical symptoms, their spiritual symptoms, their psychosocial issues. We try to address all those issues. So that's what it is. So my first few years in St. Vincent's trying to change the culture, and it's a process. It's a years and years long process, and changing the culture in society is also a process. is really to kind of distinguish ourselves. We're not the guys, you know, I said, I'm not an end-of-life service line. If you think of me as the end-of-life team, the DNR team changing their code setters, you're missing the point of what it is that we do. And certainly we're not clear about hospice. Let me just pay, again, hospice is, we could have hours and hours talk about kind of explaining the differences between palliative care and hospice, but just kind of, you'll see this, if you go to palliative care talks, you'll generally see this slide in some form. They've actually made the lines less block-like, but they're still basically it. So they kind of overlap, right? So at the diagnosis of a chronic illness and a terminal illness, right, you know, you can still pursue disease-directed therapies, right? That's the code word for we're going to continue to treat. And that's, a lot of times they remain the same. But at the time of the diagnosis, you're already in palliative care. And that's, I think, the myth that we have to kind of break through. As we get closer to the end of life, and so the way that typically one big insurance company called Medicare describes it is less than 6 months, that's really when you become eligible for hospice-type care. So hospice is a palliative care program. All palliative care is not hospice, right? So you just need to kind of take that away for us. So I have this very complicated, I stole this from, by the way, just in full disclosure, none of the slides are my own. I steal shamelessly. I'm a stainless, so I find and I always Google hospice, you know, and I look and I find PowerPoint and I, oh, this looks like a good slide, I'll steal this one. But I always try to give credit from who I stole it from, so inevitably. So I go to great lengths to, and I'll spend hours just, why don't you just make your own? I got to find one slide that does it better than I did. So anyway, so the World Health Organization, and they define palliative care, and this was in reference to cancer therapy. I'm not going to make you read the slides. I think the slides are going to be available, so we can make those slides available. So you can see it, and we'll have all the references to where Fitton stole it from, stolen from. So anyway, so I go through this, and it's the pain and suffering, and we'll go over the definitions, and we're going to bombard you. I don't mean to speed through this, but we have a lot of ground to cover, so I'm going to hit you with a lot of facts next. But I think the most important piece of this, and let me just see, because I'm not, so what I'm seeing is different than what's displaying, is really this first sentence here. It's early in the course of the disease. And the rub is early in the course of the disease. Where's Lisa? Thank you, Lisa. Oh, so it was a very, very, very moving presentation. But that's the point is, it's early in the course of the disease. It started it started when she went to the neurosurgeon the next day after Stanford Hospital. That's when palliative care started. They didn't realize they were doing palliative care, but that's truly when palliative care started. Your instinct was right. Because this is really what we struggle with. What is palliative care? I have to still stay close because I don't know if you can hear me when I step away from the podium, so I apologize up there. Were they extra? What was the charge for those seats up there? Were they charging extra for that? Because if not, there'll be an upcharge. Because I think we said earlier the heat's going to rise up there, so we know those are the warmer seats, so it'll be crowded. I always say there's specialized palliative care. So I do specialized palliative care. All I do all day long is palliative care. And I also do informatics. I'm the data guy for our hospital. So who does full-time palliative care? So palliative care with a capital P. That's what that who does it? Anybody else? There's a few out there. Thank you. Okay. So generalized palliative care. Who does generalized palliative care? What does that mean? So generalized palliative care is you address physical symptoms, you kind of acknowledge physical symptoms, you provide care. Anyone doing some generalized palliative care? Everyone raise your hand. If you've ever touched a patient, you're doing generalized palliative care. If you've ever helped a patient, even if you're a caregiver, so everyone's hand should go up for that. We do palliative care all the time. We just don't realize it. We don't call it that. We got fancy and started calling it about 20 years ago, but we're all doing it. We just didn't realize we've been doing it. We've really been doing it since the time we really started to understand medicine, right? And that's really, I think, the most important piece. I did this slide. I one of those guys that do their slides to the last minute. My wife can attest at 11 o'clock. I was thinking maybe I need one more slide to kind of poison them, to death by slides, right? So I know it is a common epidemic amongst professionals. So the patient really should be in the center of this, right? So really it's all about the patient, right? It's about patient-centered care, and that's really what we're talking about. But fundamentally, we all went into healthcare to help people. It's the right thing to do, right? It's the right thing to do to acknowledge it, right? We're in a business school. I always have to throw in the cost, and it's cost effective. It's cost effective for patients. It's cost effective for the families. It's cost effective for our healthcare institutions, insurance companies, hospitals, nursing homes, skilled nursing, nursing homes, home care agencies. So it certainly is that. Patients are happier, right? So patients generally are happier, right? So their symptoms are being addressed, they're being acknowledged. So patients generally are happier there. Caregivers are happy. When the person you're caring for is content as best you can, then the caregivers tend to be happy with it around. So it's a win all around, and I think that becomes very, very important. So we're talking about the what. We've got to kind of shift gears and talk about the whys now, right? So why do it, right? So this is now really this part of that. I think this is really one of the money slides, so to speak. This stuff you have to understand. Now, it's a little bit overwhelming, but let me just talk some, again, it's going to be economics. It's stuff we don't need to want to really think about. For the young people, say sub 30, and you can't raise your hands because I think that's, we can't acknowledge that. But just, if you were to guesstimate how much you spend in healthcare a year, how much does it really cost you for healthcare a year? Do you actually spend? How much do you actually consume? Would you guess around $500? If you had a physical, $500, right? So that's about what it could be. But if you're young, no medical problems, you're right. If you have no medical problems whatsoever, about $500. Just kind of numbers, just a ballpark. How much does it cost for a physical? I'm a family doctor by training. Basically it's $80 to come into the office. That's about roughly the going rate, right? So if you had a cold once in a year, a cold and then you got a physical, maybe you spent $250, $500 in healthcare for the year, but that's it. If you have insurance, your cheapest insurance policies are probably $18,000, $20,000 a year. It's not, and the business guys will love that return on investment. I hear them applauding in the hallways. What a great business model it is. As we get older and we start to consume more healthcare, it's a different story. Medicare spends, and again, I will point to this slide, but Medicare spends on average, if you kind of took that line right from the beginning of that 14.5 down to about 5.2, on average, it's about 10 grand a year for every Medicare beneficiary when you average it out, It's important numbers to know about, right? So you hear all these horror stories. We spend, most of Medicare's spending is spent in the last X amount of years. I don't get bothered by that because the truth is that's true for everybody. As we get ill, there tends to be a spike in spending. The reason we point it out is that we know that to Lisa's point earlier, is that we do a lot of excessive spending in these last years. That's that top line. I don't know if this display is green, but it's that top line that shows for people that are approaching end of life, we do a ton of spending. And where's that spending going? It's typically going to hospitals, right? It's typically going to hospitals and pharma, right? That's the big cost because all things being equal, you've got your normal stuff that you go for, your testing and stuff like that. But when you see those spikes, it's really because of utilization of the real big money things, right? The hospice, or the hospital services, your pharmaceutical costs, your skilled nursing costs after your stint in the hospital. That's where the cost difference is. I see people starting to glaze. We're going to stay with me. You got to stay with me because this is the hard part. You can't talk about palliative care unless you understand this. Okay. Let me just make sure. So just kind of as a general rule of thumb, the good news about this slide, and I think I stole this from Kaiser. I steal most of my slides on healthcare economics from Kaiser Family Foundation. It's a great site it's very readable, and so they're a great presentation. The good news is I think you see that as people age, as they progress, we tend to spend more and they tend to kind of align, right? So we see less cost spending in that really those highest cost centers, which are hospitals. Okay, I just want to tell you, these are the next series of facts that we're going to kind of hit you with, and then the rest of the today is going to make sense. If you don't do this work, it won't make as much sense to you, at least from my perspective. So the baby boomer stuff, we have to talk about the aging population because you young guys are going to be taking care of me. And so we have to talk about that as really the next stage of it. And we have to address caregiver issues. We have to talk about these things. And so I'm going to go these step by step. The last thing I want to talk about again is what we call it's quality of life, right? So we talk about, and this is an old kind of public health term, and you see this in healthcare economics, quality adjusted life years, right? So it's a simple concept. I'm going to explain it a little bit later, but basically, if perfect health is 1 and dead is 0, so that's the number, right? And so if you say, listen, I have one year of perfect health, it's 1 times 1 is 1. If I have 1 year of medium health or halfway health, it's 1 times 0.5, right, which is 0.5. And it helps us give some value to that, right? So the difference is 0.5. How much are you willing to pay for that 0.5 quality? And you think about it, it sounds like it's a stray fact, but the truth is, it permeates everything we do when we say there's value to what we do. How much value is there to it? Dollars and cents wise, et cetera, et cetera. So the baby boomers. So this I stole from the Census Bureau. I'm shameless again. This is a great slide from the Census Bureau. Pay attention to the graphs, not so much to the verbiage. You can look at the verbiage if you can read it. You're young. I know you're young, or you have binoculars up there. But when we look at this, here's the scary part of this slide. And there's no way to easily highlight, but I'll just tell you, towards the middle of the slide, I have to even struggle to look. By 2030, I know the slide. So by 2030, there's going to be about $70 million, 70 million patients on Medicare, age 65 and above. And so for those of you who don't know, the baby boomers is really if you were born from 1946 to 1964. That's the population that we're talking about. So at that time, when you look, there was about 71 million people born in that time period. We think that peak time is going to be around 2030. So we have to start to prepare for that. That's not that far away, right? It's really, we're talking about 18 years, or 12 years away. That's why I'm not in the finance school. My math is really, I struggle with the math. I push, but I have to know it. And the scary part, when you look at that, the lower part, that lower graphic, and you can kind of look at this side, and it's very interesting, that's really the 85 and plus crowd. And if you see, that's continuing to climb as well. And the impact is that, you know, these are people with multiple medical problems, right? These are multiple chronic medical problems for the most part. So it's not just one disease. It's not like they're just taking something for their blood pressure. They typically have all those age-related chronic conditions that go along with this. Okay, I could spend hours and hours on this. So I'm going to take a drink of water because I got to gear up to make this point. Unpaid caregiving. Something near and dear to my heart. I think it is the kind of the really another tsunami that we have to deal with. So anyone, as I said, you take time off to provide, right? I always say, especially as you're chronically ill, you know, and as Lisa pointed out, it's usually a two-person exercise, right? When you start to get chronically ill, you need somebody to drive you to the doctor, right? You need somebody to help you get to those appointments. So it tends to be that, right? So even if it's just you had to take a half a day off from work, and you start to kind of add that up, when you add it up, there's a lot of little numbers add up to huge amounts of hours spent in the United States. And 60% of the caregiving done in the United States is done by females, right? The average age of the typical caregiver is about 50 years old, right? So here's another healthcare, here's another economics thing. That's our prime earning times, right? So now you've taken off at half a day, a month, 3 months, 4 months. Now the person I'm caring for, it's 5 years. I've had to take a different job. I've had to take a less well-paying job to be able to have that flexibility to be that caregiver, right? Those numbers, those same like, oh, it's innocuous, it's drip, 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 the next thing it's snowballing, right? The reason this becomes important is, 20% of our caregivers now are over the age of 65. They're the people that also have healthcare needs themselves, and they're providing care. These are not trivial numbers. If you do the math, if you figure, anyone work in home care? How much is it roughly, just a ballpark, just throw out a number. What does it cost per hour for, say, like a private caregiver, like a PCT, right? $25 an hour. So this number that we talk about, $470 billion every year is spent on unpaid caregiving. The way they calculate that number is they kind of say, okay, if you add up all those little hours, and on average about 18 hours a week, and you multiply it by, they give like $13 an hour, right? You'd be lucky if you could hire a caregiver at $13 an hour on the open market, right? If you were to kind of do it. If you were to kind of multiply that up, it adds up to $470 billion. That is a lot of money. Does anyone know how much Medicare spends per year for all the medical insurance, for all of it it provides? Any guesses? About $500 billion. It's almost equal to healthcare expenditures for Medicare, Medicaid. How much does Walmart bring in a year? It's almost as much as we spend at Walmart, right? That's really the important piece of it. It's huge money. It's huge money. And where is that in the equation? You don't see it in a lot of equations. That's the problem. It's just unaccounted for money, right? So, but you're talking about really $500 billion of just care that goes out there. If I was a government, wouldn't I just love to tax that money? Because that would be revenue for me, right? That would be a great thing for us, and it would kind of help with that cost. So, this was just kind of the impact, just to kind of give you a sense of the spending in the United States. So when we look at healthcare spending in the United States, we look at what the government spends, right? It's about $588 billion for Medicare spending. If you redid this pie, right, so the United States spends the total budget, almost $4 trillion. If you factored in the unpaid caregiving, it would be a big piece of that pie, right? So we're with us. I have to kind of build up to this. You have to kind of understand this. So who cares? If we paid the taxes, that's what it's there for. Right, I think that's really, that's what we paid into this insurance, right? We want to be able to use it. But here's the problem, insurance doesn't cover everything. And this part is the other piece that we have to kind of deal with, is that there's out of pocket, right? Everyone's insurance is creeping up. And this is old data, by the way. So this is kind of old, so those numbers are only going to be higher. So those of us who are not lucky enough to have Medicare, we have a co-insurance or a copay or a high deductible. Those numbers are only coming up, right? And if you're lucky enough to make it, you can save it because it's tax-free. But if this is your savings and you're spending $12,000, $14,000 a year out of your life savings and you are living for 5 years with chronic illness, that adds up to big money. And we're talking about bankruptcy for a lot of caregivers of these people because that's all their savings. It's all gone because you're spending it on out-of-pocket stuff like prescriptions and medications and things that just are not covered by insurance. All right. So we talked about the finances. Let's talk a little bit about the workforce. I'm going to talk about the palliative care with a capital P. That's what we would be, and there's a few of our friends from the VA are here, but the palliative key. So the top gray, that lighter gray, is really the need. Now, again, it's how much of an impact, right? You can be kind of very liberal in how you display the need for palliative care or be conservative. But this is kind of the worst case scenario. But what you see is that bottom gray, the dark gray, towards the bottom is really, that's the number of palliative care providers that are truly doing this on a full-time basis are out there. It's just not enough of us, right? There's not enough of us. We have the highest burnout rate of most medical subspecialties. We burn out about 60% of the time. We go back and find something else to do in medicine. But we have a pretty high burnout rate. And so as they come in, we burn out, so it's kind of, we're not really seeing this big blip in palliative care, right? So that's that's an important piece about that. The other important piece, and this is also, this is another slide again. I love the Kaiser Family Foundation, thank you. So we should put them on the brochure just to thank them for letting me shamelessly lift their slides, is that we're not good in healthcare, especially as providers. We are not good about talking and documenting and giving that permission to have conversations about a more palliative approach to that, right? So when you look at this is not old data, right? And again, their sample was, I think, 5%. But it's a big group where they say we're really not doing a good job of discussing palliative care, end-of-life wishes, goals of care, et cetera, et cetera, et cetera. They're euphemisms. In my mind, they're part and parcel of the same thing. The other piece is about documentation. We can talk about that a little bit, but I just want to stray. But the real important piece in this one is that graph to the right. It would not be a palliative care talk if Fitton does not display this disease trajectory slide. If you do not believe in this slide, if you do not believe that these are pretty much the only three ways we get off the earth, unless there's a tragedy and it just stops abruptly, then you can't do this. You just have to leave. There's coffee. I think we could still give you the box lunch, but so you can leave early and cut to it. So this is the way. There's one of three ways we get off the earth. And these are one of the three ways. The top graph is typically what happens. So if you can't read, it's function is right. Function, for those of you, is on the vertical side. Time is on the horizontal side. So we tend to have high function. We're doing well. We're doing well. It's all relative, right? So this can apply to a child. This can apply to an adult. This can apply to a frail person. That's the cancer slide. They typically get cancer. They're doing well. You start to see some symptoms, and then parasitally, their ability to care for themselves is impaired, right? So their care needs all of a sudden shoot up for that, right? They were doing fine, and it appears as though they just fell off that cliff, right? So that's what that graph depicts. The middle slide really is a slide for the bane of my work, and it's really the bane of how people die in the United States. We typically die. It's your end-stage heart disease, it's your end-stage lung disease, so your heart failure, your COPD, your end-stage kidney disease, your end-stage liver disease. So your big organs, that's typically the path, right? We have this waxing and waning, and so we get sick, we have an exacerbation, we go in the hospital, they make us feel better. We get back on our feet, we maybe do some rehab work, we get back in our feet, but we're never better than what we were prior to that. And it's this steady downhill course. I will not talk about the epidemic of dementia. That is the other healthcare epidemic that we are kind of dancing around right now in the United States. But that lower graph is really what I call end-stage neurologic disease. That's typically the trajectory. They have this low level of function, and they can persist in that low level of function 5-7 years. And so it really that's that slide. It's an epidemic. It's a whole nother conference, really. It's really something. How do we talk about that? So we're going to talk about palliative care in the United States and then kind of segue to the community thing. I just want to look at the time, 37. I'm doing okay for time? I'm doing okay for time. So it really started, the capital P palliative care really started, we have our roots in hospice, right? It started from that hospice movement. And more and more people saw, as medical technology was increasing, we're kind of doing stuff that just didn't make a lot of sense to the people providing the care, right? So there, you saw this kind of these roots of these movements, and it's grown and grown and grown. And it really has grown up in hospitals, right? It's really, even still to this day, 2017, most palliative care is delivered in the acute care setting. There's a problem with everyone saying that's the wrong place to do it. I know we're going to get to that part of it. And there's tremendous evidence, and the evidence is getting stale, so I have to just disclose that. We need to revisit some of the evidence, but there's tremendous evidence that it's been a successful program. It's been a successful intervention, right? So IPC stands for Inpatient Palliative Care. So we do a better job of controlling symptoms, right? We do a very good job of doing that. We improve quality of life for patients and for their families, right? So we certainly have done that. Patients actually live longer. When we can talk some people, there are studies, Tim L. and others, that say actually not doing some cancer or disease-directed therapies, particularly in cancer, people actually live longer because typically it's the toxicities of those third-line medicines or those second-line medicines that usually kind of accelerate their demise versus if they hadn't done it in the first place. It saves money for everybody, again, and I think that becomes important. And when I say it saves money, I'm really thinking of patients and their families, right? I do think about the societal cost, but really I always think about it from that perspective. And that's why I brought that other slide up earlier about that. Okay. So back to those people that said, oh, you're right, we're doing it too late. So again, this is typically the acute care setting picture, right? This is where we've started, those blue arrows are where typically we're involved. We're involved at their end of life. So we really de facto, for us, it's almost an easy win. You're able to do it because you're interceding at the end of the life. It's almost a no-brainer for us, right? It's very straightforward. I always say the easiest part of palliative care for me is the medicine because it's self-evident, right? They're at the end of life. It's so easy that I can't make bad jokes about my other colleagues in medicine, but I will. I'll catch me others, and I'll finish that line. So this is a summary slide to kind of say, let's look at kind of, generally speaking, palliative care in the acute care setting. About 90% of hospitals, more than 300 beds, have an inpatient palliative care program. And when you look across, even hospitals as low as 50 beds, and those are small hospitals, it's expensive to have us in some service. Have some several, so almost 60% of hospitals, more than 50 beds, have some sort of palliative care program. There are still opportunities, right? There's still plenty of opportunities. We need to do a better job of communicating to our community providers, whether they be nursing homes, home care agencies, to patients, to primary care providers. Where are we in their illness? Where are they as far as communicating their understanding of their illness, their education, their understanding, their awareness, their readiness to kind of embrace those next steps of, I want to focus on just quality of life issues. Where are they? So we need to do a better job of that. I heard it this week from a dear friend of mine who I went in to see a patient who was 79, I gotta make sure I'm not violating any privacy laws. 79 years old, he's not from this country, came to visit a family, had some chronic kidney disease. He comes in very sick. His kidney disease, believe it or not, if it got worse, it got worse. He was at a point where he was too weak to stand, he couldn't do anything. And one of our dear friends in the ICU said, I don't know why palliative care is seeing him. What? So let me go back to that slide, because I always whip that slide. I carry it in my lab jacket. Look, this is where they are. I'm just telling you what I see. This is where they are. So even now in 2017, in the acute care setting, I still hear that fairly routinely. It's too early. What? It's too early. They're in the hospital, and now it's hard to get in the hospital. They're in the hospital, and it's too early to talk about that. The other part of this is medicine's a business now, right? So we're in the business school, right? So if you turn on the TV, depending on what time of the day, there's a health system that says you're closer to free and there's some really catchy tunes, or you're seeing ads from a cancer center in Philadelphia where you go there, it's cured. It's just come here and we'll fix it. So there is this marketing of technology that we're competing against. And really still, we've made tremendous progress, but it erodes at that progress that we make, right? Because, I just go to that hospital system, it's free. We used to be affiliated with a cancer center in Texas, and they had the line through the cancer ward, that the cancer was gone. They crossed it out. Good for you, I gotta go to Houston the next time. So everyone should have gone to Houston. But this is what we're dealing with. In the cardiovascular world, again, cardiovascular disease is the biggest killer of adults. Those are all those initiatives, right? ECMO, right? There's any way to bypass the heart to try to do that, right? So there's just more technology. TAVRs, right? So these transcutaneous valve replacements, that's what TAVR stands for, right? Clippings, all these devices, they're hugely expensive palliative care procedures. That's how I look at them. You don't fix the chronic illness, but you might make them feel better. And remember I use that word quality, that quality adjusted life years? Well, you can put some numbers to it. That's where that applies, right? So you've got to be able to speak that language. What quality? What's the value that you added to it? And how much are we willing to pay? There's no answers for this, but you just need to think about this going forward. That's that study, that Tamel study. I knew I left that slide in there. So anyway, that proves that that's a 2010 study. So Jennifer's out of the Harvard area, and she kind of demonstrated that actually people live longer when they actually do less is better, right? Again, I just want to talk about this because it gives us then, so we've talked about the need, right? So we keep building, everything we've discussed is this need for palliative care, or this need for generalized palliative care, right? The numbers bespeak it. The workforce, there's just not enough to do it. So we need everybody to be involved in this. We need everyone to feel comfortable with this and to have these conversations, right? So that we look and we say, okay, there's plenty of evidence to support. So whenever you see this, is by the way, again, it says healthcare economics. But when we look at this, and I'm running close on time, so I'm going to try to speed through this. I think I'm close to the end. So do I have a little buffer? That's not what I was looking for. Okay. So anyway, so when we go to the evidence of this, so we look at this, and when you look at, again, the lighter blue means there's a lot of evidence, and the darker colors means there's less evidence, right? Because we're saying these studies are great, they support it, but when actually you look at the quality of the studies, and that gets down to the research, guys, challenge the assumptions. When you look at the quality of the studies, they're not there. And when we talk about resource utilization, here's the issue, guys. Here's the issue. The unpaid caregiver stuff, it doesn't go away, right? So because we reduce the readmission risk, because they're at home, doesn't mean that their risk has gone away. That cost is not factored into most of these studies when it talks about resource utilization. So again, we talked about market disruption, right? We are losing the shift from inpatient care to outpatient care continues, right? Nursing assignments are continuing to be stretched. We still train all of our patients around the epicenter or train all of our learners around the epicenter of medicine, which is the acute care hospital, but that's, generally speaking, you're seeing a move away into the community from that. That is the big market disruption. Somebody finally started to look at the economics of this. The way we get paid is going to be paid differently. We're going to get paid in bundles of money versus getting paid a la carte for every test or procedure that I do. Care continues in modern medicine to be fractionated, which means there's more specialty people involved. I see a doctor for my heart, I see a doctor for my lungs, I see a doctor for my kidney. It contributes to that. So there's a desperate need for primary palliative care. That's the point I want to try to make. I'm going to talk about this readmission risk. This one point on this slide that I want to talk about is the readmission risk, right? They came back to the hospital. My heart failure patients came back to the hospital because they ate Lay's potato chips. They didn't take their Lasix. They didn't do it. The truth is that's a myth. They came back because no one addressed the primary issue, which is they have a chronic illness that is progressive, and we really didn't put a good plan in place to manage that exacerbation. They come back because they don't feel well. We don't need to do more tests to tell them that we know why you don't feel well. Your heart doesn't work as well as it used to. But we knew that walking into it, right? So that's that myth, right? But the cost doesn't go away. It's just no one's doing the accounting for the cost of it. All right. So we all agree we need to push it up the line, right? I think that's really where we need to go to. We need to kind of push it up the line. And this is the purpose of events like today, to stimulate you to understand the basic facts and so that you can be an effective, educated person in whatever you do, in whatever aspect of healthcare you provide. You understand what we're dealing with. We all need to kind of own this, and I think that's the important piece of it. You are all palliative care providers. Don't wait for providers and physicians. We are your weakest link. Start conversations early and change the culture. That's really what we're trying to do. These are my wrap-up slides. I only went over by 2 minutes. We need a new name. Everyone needs to do that. There's a big door prize. Corey, what was the door prize again for the new name? The best name. So anyway, we're still working on that. We're going to do a GoFundMe for that. And so, but it's never too early. The other piece of it, the other takeaway, it's never too early to do it. We're all capable of providing primary palliative care. And the problem is, the other piece of this is the model for palliative care is we can't be a specialty clinic. We need to embed ourselves in a patient-type medical home. We cannot be a partial lot. We cannot contribute to the fractionalization of healthcare, which I think we've made some mistakes, quite honestly. That's an opinion thing. We've made mistakes in ambulatory palliative care, outpatient palliative care. We should not be a specialty clinic. We should be part of the patient's medical home. We need to do that because the more we take away from primary care, the less skilled. Back to that slide about not discussing it. If they're not seeing it, they're not going to discuss it. You can't blame them for doing it if they don't see the patients, right? If they're only seeing them to fill their thyroid medicine, you can't blame them that they didn't engage them in the goals of care conversation. When you've taken all the symptom management away there, you contribute to that palliative, that partializations. I put up some training issues. This is what we need. Guys, we need programs that specialize in palliative care. You need to understand public health. You need to dabble in all these things to really be kind of effective as far as leaders in palliative medicine. You need to kind of understand. And I left the right side of that list to continue to think things to add. So this is the part where you guys have to add to this list. We need to think about different models of delivery. We need to think about telemedicine. We need to embrace things that we typically wouldn't have done because we need to stretch these dollars. I ran a little bit over. I was going to do some Q&A, but we have some breakout time. And I know I'm out of time because we're on a break, right? So I'm chewing into your break time. But we have some panel discussions. I encourage you to write down questions. And I'm getting any other signs messages I need to come back. I would want to whet your appetite. Thank you, guys. All right.